So, I mean, we're going to talk a little about telemedicine. So before COVID-19, how many people heard about telemedicine? No, it was like very unpopular. I mean, you heard because you were here with me before.
Yes.
But no, it was very unpopular. What do you know about it? What is that? A doctor on TV, doctor in a box? You know, Serena, by the way, you did pay attention because I'm going to pick on you. You know that. Okay, so I mean, so we'll talk a little about telemedicine, specifically Tele-ICU. Okay? And see how many critical care experts are available in the US to take care of patients. How many times do you want to keep going in the room, exposing yourself? You know, would you like somebody to be, the camera in tells you well, something's happening and just call you on your phone, tell you, okay, then you're going now, and that cuts you, you're going in and out. So telemedicine has been used to save the nurses from going in and out. Most infections are happening downing and doffing, you just said that. And the downing part is more important than the downing part. So people rushing in and out of the room, minimizing that, using PPEs back and forth is a very important thing. Did we know all this? This just developed. So this was the original ECMO setup and Tele-ICU setup. Tele-ICU setup. It requires digital technologies. I'll tell you one thing: HSS, as well, the HHS has approved platforms that were never approved before for Tele-ICU, like Zoom. Zoom right now is approved as a Tele-ICU, vehicle, which was before something unheard of. But believe it or not, some hospitals are using Zoom in the state of Texas for the docs to take a look at their patients. And then they must examine the patients and make recommendations. And so, I mean, and this all came after COVID-19. I mean, you can be very fancy, have a big Tele-ICU center. There's one of the hospitals here, I cannot name it, has a massive Tele-ICU center. That's like a big hub. They spend a lot of money on it. But again, we're going to see some small centers. You can actually do it from home. Now there's, and again, I have no relationship with this. There's a platform called COVID-19 MD. That's where you get COVID-19 training, and then you call your doctor. They recommend stay home, quarantine, or you need to go to your nearest ER. Remember, there's a lot of people who were told at the beginning of the epidemic, stay home, stay home, stay home, because they want to go to the hospital. Right now, we're seeing the opposite. I'm sure you're seeing the same. People are staying home, having MIs at home, think it's COVID-19. I know Joe had that experience and was very unhappy about it. People who have massive CVAs think it's COVID-19. And I'll tell you something, you need, and that's what COVID-19 platform should be used for. It's kind of distinguished. It's not that easy because you're doing a televisit, you know. The transplant center is following up their patients that need to be followed up on a monthly basis by telemedicine. And they've been, in the beginning, there was very foreign to them. They had no idea what it is, how to schedule the doctors. Now they're following it up and they're doing an excellent job. The patients are only coming in for the labs checked. Am I correct? Yes. So, I mean, that saves the patients from going in back and forth. Is that going to be the new normal? Probably. Because the patient now, instead of going their iPad at home, do you think they're going to want to get in their car and drive to the med center, park and pay and roll that and do all that? I mean, things have changed a lot. So you can thank a little COVID-19 for that. You know.
Yeah.
I mean. So we'll talk about a few things, this is the availability of, critical care beds in the whole world. So look at the US, So we need to use it judiciously. And the only way to use it judiciously, if you remember those days, leave a patient in the ICU for a couple of weeks, it's not going to transfer them on a Sunday. It's not going to transfer them. And you have somebody aggressively winning the ventilator. I mean, the docs are not available all the time. I imagine it's easy for you. And unfortunately, I'm very familiar with the situation here. I know which hospital has it, which should not have it. I mean, if you're able to call when you're sitting at your chart at your desk, send a link to your doc, take a look at this patient, tell me what you want to do differently. And I mean, you have amazing critical care docs. Imagine if you have access to them 24/7 without that coming to the hospital. And you have to look at the economics. Having a doctor in the ICU covering 24/7 is expensive. So unless you have access to the doctor in a different way, make it easier for them, either from their house or a center, you're gonna have access 24/7. Better for you, better for the patients. So, remember this whole thing with the news, and I know Joe doesn't watch the news we watch a different news. The whole thing about how the bad situation getting overrun again, and there's the alert system. You know where this alert system came in? This came from the TMC, the occupancy of the beds. The occupancy of the beds, we went to occupancy more than the beginning of April. So our current occupancy is more than the beginning of April. So it sounded the alarm to the judge and to the governor, that this is happening, and help to manage the situation. You heard about the field hospital in NRG. how are they going to staff that? You think there's fewer critical care doctors running around? So I'll tell you, I mean, there's now, there's even a language put in by the government, by Medicare now. I've seen and examined this patient by HIPAA compliant two-way technology. I put that at the end of my note of my chart. Did that ever exist? You ever see that before? So this is how all of us are working to take care of patients. So I'll tell you, I've been very impressed with the government involvement. For me to say that, that's a lot. So here about, how many critical care docs we have available. And we don't have them. That's the biggest shortage we have. And they are expensive to have them 24/7, I promise you that. Some of them are gonna kill me now for saying that. Now, you imagine if I'm at my house, I can pull up your x-rays, your CAT scans, and manage you, look at your hemodynamics. So not only just look at the chart, but sometimes look at live hemodynamics, cardiac output, cardiac index, and I can look with the camera without bothering you to go into the room. Go look at the camera at the pumps, see how much lever you're running, how much EP you're running. What's your last index? I can pull up the trend of your indexes, the trend of your wedge, and all that. You're going in and out of the room, and that's amazing. Another thing which have been used to, we have been hearing a lot about the families not saying goodbye to their loved ones. I'll tell you something, it would bother me a lot to die alone, probably a lot. So now we're able to send the link to the family to see their loved one before they expire. That's something amazing. And also able to send the link to the consultant. You know what I'm saying? I know about critical care, but I don't know about everything. But I send a link to the lung transplant physician, the heart failure physician. What's your thoughts about that? And to be able to provide that link again. So it's all about making technology work to help us take care of patients.
It's also it's giving patients access to experts that they might not have.
Absolutely. Every journal, every website has jumped on this situation. I'll tell you, everybody wants an investment jumped on that situation. Mm-hmm. And again, we can be very fancy two-way video, e-alert button, you push the e-alert, the doc comes on. But I'll show you different modalities, like how things can work. Here's the typical ICU room, and since adding more people in there, we just can camera in there. And that actually became like a new expression. I'm gonna camera in the room. Here's a very fancy structure where you can see the patients, and the patients are all logged in. I click on the patients on the live stream, and I can pull up all the numbers I need to pull up. I can pull up their labs, and the last trend, the X-ray, the CAT scans, and if the patient is coding the red, it's like red, yellow, green, the usual. So red is coding, yellow is like medium, okay? That's an e-care manager system. Is that system cheap? Cheap is not at all. You can imagine working in law enforcement, this kind of high technology is going to be very costly.
Oh, yes.
Yeah. Can every hospital afford having a hub like that and cameras all over? No, probably not. So a different way of doing things. So that is an expensive way. I'm gonna have to say that. So the ICU center should have board certified critical care physicians with protocols and guidelines. And these guys are going to be in one hub, and they can manage multiple hospitals. Between them and APPs, they make a certain team. The APPs triage the calls and the route of the physicians. And they know the capability of each hospital. And the good thing is it becomes like a command center. They can move patients from one hospital to the other. This hospital doesn't have this capability, I can move it to this hospital. Mm-hmm. And there's actually some centers in Florida have gone with an amazing system. And they use the color. They made transplant green. They made cardiac red or blue, depending on the cardiac surgery or MCS. And they would move the patients from different hubs. Like here, I'm just going to use Methodist or St. Luke's as an example. You have Woodlands, you have the medical center, and you move them from one area to the other where the bed is available. And you can see that on one big screen. You don't have to struggle. You don't have to go to the transfer center right now with an accepting physician. Now you have one hub controlling that and able to move the patient to the best care possible. Are we there yet? We're not. That for sure not there yet. But that's what we're striving for. It's very important for ECMO patients, for sure, that ECMO has to go to expertise areas. For referrals for transplant, MCS has to go there. And I'll tell you something, patient codes, can you lay them and then send them to a place where they can take care of them after that. That place will have the OR ready to take care of them. like you said, every place has, Stephanie was saying, ORT might not be available. Other places, you have to look at the system, see what's available for you, send the patient there. So it's not about technology, it's more about patient care optimally.
It's coordination.
It is coordination, and believe it or not, in the end it becomes very cost efficient because you're moving the patient out to the best available facility that has available beds. There was a decision made early in one of our institutions that the patients are not going to get tubed for COVID-19, like low-level sick. They're going to go to a certain hospital, and that's where they all went, and they stayed there. And then the infection hub center, And then the ones that are going on MCS or ECMO, they're going to go to the med center. That was an excellent decision. I'll tell you. And their care has expanded to multiple units now, being able to take care of ECMO patients. And something makes you proud, They were innovative. They thought about, instead of moving the patients around, the patients were moving around to where the nurses can take care of them. They decided to move the nurses around. And the nurses were actually happy to move to do that. And those nurses taught those nurses to become like a hybrid model, you know what I'm saying? So it wasn't only the ECMO nurses from the cardiac surgery unit. It was the medical ICU nurses now are able to take care of ECMO patients. The ECMO specialists or the perfusionists there to help. And the e-ICU doctor is available to them for immediate consultation. There's no delay, there's no downtime. And that's the whole thing is, they press the button, you get a notification immediately that there's a situation you need to respond to. And I'm just, nitric oxide. You cannot, although nitric oxide right now is becoming very cheap, believe it or not. Really, really cheap now. It's not about, still there is equipment to get it going. That's not available in every hospital. Nitric oxide have saved people from ECMO, have saved people from intubations. Now, there's a new way of misting nitric oxide. There's a bubble you can put in your head. I don't know how it feels wearing it. I would probably be like tearing it. It's like a cluster part. So it's basically like a big jar they put over your head, inflate with oxygen, and the nitric is misted inside it. Okay, and it's called a helmet. You've seen it on TV. Mm-hmm. Yeah, and I'll tell you, it has saved the patients from intubation.
Mm-hmm. I'd rather just put the cannula in.
Okay.
I'm not taking the bubble. I'm not doing the bubble.
Daniel was talking about drugs. At some point, Nimbix ran out, and there was a big back supplier in Nimbix.
That's unbelievable to me. That's unbelievable.
When you use how much? Well, you have to remember.
Because Nimbix comes from China.
How much Nimbix? What does it put you on China? How much Nimbix was being produced? Was produced with the war. ICU sedation every now and then, but wasn't that mass production? What was never meant to be. You cannot blame them, So for that to ramp up just like that, it's like everything else, like ventilators, like everything could not ramp up like that. Mm-hmm. Now Nimbix is back in supply. Listen, remdesivir, they ran out of remdesivir, and now, it's the same thing. If you use something so much, they're going to run out. So, you're able here to triage your resources and moving around, Like somebody asked me the other day, and again, it gives the experience. I'm going up on heparin, and nothing is happening to my PTT. And I asked a simple question. I'm not that smart. I asked a simple question. Have you checked antithrombotic level recently? And the answer was no. Am I smart? No. Do we do these things routinely when you have an ECMO patient? Yes. That is one of the protocol. You know what I'm saying? Roxanne taught, we have to know for everybody, that NGMX, you're not bleeding as much. I did not believe her in the beginning. It's like, you follow it. But actually, she had the literature to support it. That you're not bleeding as much on NGMX like on heparin. And I have a big fear about HIT. So really, I've converted to NGMX is becoming an easy trigger for me like that. We have a pharmacist that can run the NGMX. Am I smart? Do I have the time to follow NGMX? No. So I'll tell you have to transfer to a specialized center. It's not because the doctors, only the nurses, just availability of equipment support staff. You know what I'm saying? Our physical therapists have walked patients on ECMO, VV ECMO with no problems all the time. Does that happen every place? No. So you have to really move the patient. I think moving patients should be much easier now. And I'm finding it more. I was so proud the other weekend. Instead of beating down the vent and taking a risk, our ECMO team went out to a satellite hospital, cannulated, and transferred back. Mm-hmm. And the patient came rock stable. I was like, when the APP called, I said, really, is this patient on ECMO? Because the numbers were like amazing, And why? Because he was stabilized, cannulated on that side hospital and transferred there.
Makes a big difference.
Makes a huge difference. These patients, you arrive, they're beating down the vent, and they arrive in Q2 in the 40s. we were already way behind the 8 ball. So I mean, was the e-ICU like big part of it? A big part of the coordination, you know. They give you a notification, we're leaving to bed. Is that okay? Yes. Are we going to be ready when you get back? Yes. You're coordinating the effort in the back end. The e-ICU should be the backbone, helping support the nurses so they're not exposing themselves, getting them ready. This is happening. This was good, you know. And I would call my my RN that's watching. I say, this patient, I don't like the way he's looking, you know, and just keep an eye on. And then it's not stepping anybody's toes. The other night, the RN calls the bedside RN. I think your patient took his oxygen off. You cannot be in every room at the same time. No, it's desaturated. And that's give them support. Okay, go to the back. It was very simple. Go put the oxygen back on. You know what I'm saying? So you know that the patient oxygen stays off for a while. What's going to happen? The patient will arrest. We don't know he arrest IPE. No, he did not. So it's little simple things that we can avoid, and it's better patient outcome. So it's not just about technology. You know what I'm telling you? It's all about patients. You know, I'll tell you something. Every patient that comes through the e-ICU is seen and evaluated. We have a little summary about them, what's going on. We put that summary in the chart. In our generalized plan, consult the consultants early. We will go to the renal ID, and I'll tell you, like everybody with COVID-19, we enroll them in the remdesivir study. And we have we have an ID team that's dedicated to that. They know, get a call from us, and enroll them in remdesivir. So they'll evaluate it. They'll not have to go on, but they get that chance. They have a fighting chance. So really, it's directing the resources to the right way. Yeah. No. Okay.
There are not enough intensivists to take care of all the critically ill patients in all the hospital ICUs in this country.
At the bedside, time is a critical element. 15 minutes can be a lifetime.
The Envision e-ICU offers a potential solution for understaffing, for care delivery, for systematic quality issues that may arise in the ICU.
Prior to the e-ICU, we were having telephone communications with the bedside nurse, verbal descriptions of what the patient was like, and making decisions. We now have intensivists watching a monitor who can actually see the patient.
They can see what you're looking at. They can zoom in on the camera. They can even read a 12-lead EKG. If I hold it up, and I've done that, said, here it is.
They're able to read echoes from that. I just tell the echo tech, please direct the screen towards me. I can read the echo from the,
you don't
from the
really
camera.
have time to go figure out who to call and call your answering service. So they do that for us.
Well, my main goal every day is to protect the patient and to assist the nurse at the bedside. The nurses today have a much more challenging role. The acuity of the patient continues to increase. We have a very high-level technical system, and we have a group of people behind the camera that are very knowledgeable and very educated.
We have an established cadre of board-certified and board-eligible intensivists and established critical care nursing staff with over 400 years cumulative experience that serve as a backup for the clinicians that are acting at the bedside to take care of these patients.
That's a very common model.
In any
that's used around the
situation,
country.
the patient can be going along and his blood pressure, pulse rate, everything's going well. And then all of a sudden there's a sudden change. I can address that sudden change. One evening, I was opening the camera. Patient's ventilator was alarming. I had seen the sat drop, and the patient had a tracheostomy. His inner cannula that was attached to the breathing machine had come loose and was starting to pull out. So I was able to get the nurse in the room right away, and she was able to address the situation. Therefore, the patient did not become anoxic.
It makes such a difference. It makes a difference in saving lives. It's a safety net for the patients. It's a safety net for the hospital. The process is good.
Use of a systematic quality tool that looks at every patient every day for CMS and other measures that are important for quality of care. Rounds with the nursing staff.
We do patient rounds every night. We try to set our patient goals for the shift and sort out all our problems, and it's just smooth as butter.
We make a diligent effort to continue the care plans as established by the bedside practitioners during the day.
This has had a tremendously positive impact on the patient care as well as the physicians who were practicing during the daytime, because after working all day long, sometimes 14 hours, we would be able to leave the ICU in the hands of the e-ICU intensivist and then come back the next day and find that things had been cared for while we were not present in the ICU. After implementing the e-ICU, we were actually able to reduce the total numbers of beds that we needed to keep in service for critical care patients because we were able to more efficiently manage them using a 24-hour intensivist model, whereas we had previously only an 8-hour intensivist model. The e-ICU intensivist and e-ICU nurses are part of our team, even though they are
as
only
many
virtual
we're putting
members.
it in.
There's a lot of trust,
You
there's a
cannot
lot
be
of teamwork,
everywhere.
and that's what
You know,
critical care is.
same thing when you're going in and out of the room.
Shock
I want you
resuscitation.
to, right now to go into the room, you need to go into the room.
To run
And
in
I
and
want
out
you
of the
to be
room
able
and call the
to watch
private
3,
team
4, 5
and
ECMOs
wake
at
them
the same
up for
time. You
every
cannot
word.
watch them
Things are
efficiently
happening really,
unless
really
somebody is
fast.
providing you support.
Absolutely.
So, yeah, so if somebody providing you support, then you need to go in this room, there's something going on. You need to check on that.
Yeah, well, you're in this room, and the other ECMO is in the other tower. Now what are you going to do?
Exactly, and that's the thing is,
So you need 2 people, and there aren't enough of us. Do you think there's not enough intensivists? There's not enough perfusionists. I mean, that's just a reality. We've had this discussion a billion times.
and I'll tell you what, so I don't think e-ICU will ever replace the human factor. You need the human factor to be there. It's providing back support. So you're not able to go in and out, and COVID-19 highlighted that. So, I mean, and this can be a big fancy setup like this, but there's a much more simple setup, a reactive model. When you call me, Samir, we need to consult you on this patient. So I have a hospital I cover, they say, Dr. Samir, we need to consult you. The hospital has Zoom. So actually, we joke with the nurses, let's Zoom. So we Zoom, and the patient actually, if they're awake, they're holding the iPad. Mm-hmm. They're making me examine them. They're like going over, you know what I'm saying? You know, and the patients like it. They feel they're interacting with the doctors. Mm-hmm. And, you know, and I at the beginning was doubting that Zoom is going to work. And it's actually working perfectly. And, you know, so there's different ways you can do it. And I'll tell you, we learned from the command centers, from the airport, from the police department. They are able to manage all their operation from one center. And we can do the same, have a protocol. And these guys, when they get called, they know what to do. They have a system. Mm-hmm. We have to have a system what to do. Now, really, to be honest with you, I get called from Clear Lake, I get called from Katy, I get called from Willowbrook. It's the same system and the same expectation. And you know that they get a 3-way call between me, the surgeon, and the sending physician. All of us know we are all on the same page. There's no issue at all. Mm-hmm. And I'll tell you something, when it's really the more critical the patient, the better it is. Especially when the last weekend when the ECMO team went out there and got the patient, it worked out perfectly. We had a plan before they left. We got an update when they were there. Mm-hmm. Everybody was ready when they got back. The camera got turned on when the patient got to the room, and you know, it worked out very well for the patient. They're doing very well. They're where they need to be.
Now, so let me, and I agree with you 100% that telemedicine, Tele-ICU is, I think the title of your talk was here to stay, and I do agree with that 100%. However, and this is germane also to our law enforcement partners over here, you look at data, you look at monitors, you look at waveforms, you look at labs, you look at. Do you feel, just similar to you guys, you get a call, okay, so we're looking at numbers, you're looking at labs, you're looking at data, you get a call at the radio, see the man at XYZ corner of walk and don't walk for a disturbance, some disturbance. But until you get there and really see with your eyes what's happening, you know, they can only give you so much information over the radio. They try to do the best they can, but until you have eyes on it, you really don't know. So Dr. Samir, how many times have we seen and heard the labs look great, the x-ray looked fantastic, but the patient is no longer alive because you didn't do an eyeball test. Can you effectively do an eyeball test with telemedicine?
You know, you're striking it very hot with me today because I was told a couple of nights ago, the patient, the ABG looks amazing. I don't understand, it looks amazing. I came in the room because I'm a doubting Thomas. So, okay, cool anesthesia start. Okay, you know, and that's for me. you look to the camera. You see that the numbers, the ABG looked amazing. Patient was breathing, is hyperventilating, trying to blow off their CO2, the metabolic acidosis. They're about to die right now. So and for me, camera taking it's a quick tool. Mm-hmm. And to see and examine the patient.
Does it have the clarity you need to really see?
Absolutely. I'll tell you what, for me,
patient, their color, their pallor,
I was covering a hospital with the the cardiologist, and I hope there's nobody waiting for outside to beat me up. Serious, that
we got you.
They don't want to. They don't want to come in the middle of the night to read an echo. That the situation is happening. So for me, I asked the echo tech, please turn the screen towards me. She was like, really, you really can do that? Yeah. So I zoomed the camera to I'm reading an echo now, and I can tell that the patient has a PE because the RV was like totally dilated. Mm-hmm. Had all the PE markers, but we didn't want a high creatinine. I cannot send them downstairs for a CT, spiral CT. So the RV totally dilated. Were really bad. Put the patient on TPA. And by next morning, everything was resolved.
I thought you told us earlier that everything gets blamed on PE.
I'll tell you, PE, you ask the medical examiner, it tells me,
I remember. I remember. See?
PE is such an orphan. That's what the medical, and I agree with the PE is an orphan. It gets blamed on everything.
Exactly. So you gentlemen there, we'll close up with you guys. Do cameras do it for you? In other words, being able to assess what's happening at a scene? Or do you think the technology of video surveillance has reached a level where it can be equal to your own eyes on the scene?
I would think that our video cameras for what we do, because they're more direct, right?
Yeah.
Okay. We have to observe the whole picture, the big picture. Okay. Mm-hmm. So when we have cameras just focused on, like if it was just focused on Chief here, then we're not really getting the big picture of what's really going on in that environment. Okay. Yeah. So it's we could only do so much with that. And so for example, live PD and cops and so forth,
Do you watch that show?
No, I don't. I used to, I used to, but then it got to the point where I would get upset because I would see some of these officers making some real bonehead moves, and it's like, man, why are you doing that, but again, it's just because it's focused just on that. It doesn't give me the big picture, and he'll tell you, I'm always 2 or 3 steps ahead because I like to look at the big picture,
It's like a chess game.
Yeah, it's basically what it is.
What these people are going to do in the next 5 minutes.
Right. So, it does, depending on how you use it and what we're doing, if we're making a control buy on as far as on the dope side, on narcotic side, it's a very good tool to have. We can video exactly what he's doing, but for a call for service, as far as everyday control wise, it doesn't give us everything. Mm-hmm. So, body cameras have saved a lot of officers as far as complaints goes, but again, that's, one-on-one interaction, or could possibly do a group,
Right.
You see it on social media right now, they tried to, obviously the recent, incident that took place where all these riots, right? But nobody got anything what happened prior. Or what the other officers were doing on the other side, right? Yeah. It's just one angle of it.
Right. So I think you bring up a very good point. And Rodell, I'm going to bring this up to you and also to you, Daniel, because I think both of you have this experience. And I have this experience myself, even though I'm listening to what he's saying, and this is what happened. I have had this happen to me, where I have been in a situation with a patient who was just nothing I was doing or anything, whatever we were doing was not only not working, it was hurting them somehow. We couldn't figure out. And I've gone into the tunnel vision where I have looked at this, and then I've looked at that, and then I've looked at this, and I've done these things, but it wasn't until I was able to get out of that tunnel vision mode and just see where I was able to see what the problem was. Can you do that in a telemedicine ICU or tele-ICU scenario? I mean, do you feel that anything will, I mean, look, it's a matter of reality, and I understand that we have to be pragmatic. You need more intensivists. You need to add expertise in places that don't have it. But with that said, is there a limitation to the ability of the technology when it comes to managing patients in a truly high acuity critical care situation?
I'll tell you, I mean, somebody's.
And I'm just being controversial.
No, and I'm gonna, as usual, but I'm gonna give you my answer. Somebody not from here, from the state of Texas, sent me a case to review. I do a case like reviews, and when they sent me the whole picture. I don't think they realized how much they sent me. So when I ran the whole clip together, I can see cardiac index and output and its continuous motion, hills and valleys. And so was the case was it was an ECMO patient who post cardiotomy, and because the chest was open, they refused to accept he has tamponade. You know,
I mean, but I'm sure they had a vi drape over it.
Yeah, that's exactly it. And the hills and valleys told me, I said, I'm not that. And they said to me, we give volume, and every time you see it, they give the volume.
Yeah.
Okay, and then it goes down again.
Yeah.
So those clips show me like, okay, there's something, and was a whole picture together. Mm-hmm. They were looking at certain time segments, you know what I'm saying?
Yes.
They were not looking at when you see this continuous flow, and the thing is, it was from a very fancy system they have. And you see the index, like the airport board, which keeps changing, and then it goes up and then it goes down. Mm-hmm. So you saw that, so I'll tell you, I think it's an additional, I think e-ICU, I don't think it's it only. I mean, listen, if I want a patient get tubed, I have to call anesthesia. There's limitations for sure. I mean, and I even mentioned your friend's name. I said, unless Dr. Lopes is going to build me a robotic arm to the TV, I still will need support from everybody. So I think it helps the nurses, like she said, the patient disconnects. How many times did this happen? The patient disconnects the vent, disconnects the trach. The nurses cannot be everywhere. And you cannot blame the nurse. How come you did not see this? How come you did not hear that? There's alarm fatigue.
Yes.
You have to have somebody else supporting you.
That's another lecture, alarm fatigue.
So I mean, you really need to go into this room. There's something going on. Turn the camera, you can see the patient going on. What's happening with the patient. And I think it also works with neuro. You could talk to the patient looks off. He was normal before. You could talk to him, all of a sudden looks off. You know what I'm saying? So.
Well, I think that brings up, and I'm gonna close this out because I really do need to start cooking. I really am gonna. If y'all want to come over and come to, I'm cooking for everyone but Dr. Samir, as I said. I think my closing point for this, Dr. Samir, Rodell, Roxanne, and Daniel, and you fine gentlemen there, is that just like ECMO, you can put ECMO in, you can have the highest level of technology you want, put it in, and not understand what it does and what it's doing. Tele-ICU, you can have the fanciest equipment you want, but you saw what you saw because of experience.
Exactly.
You can't just have the most sophisticated telemedicine ICU with, and nothing wrong with people who are new, but a rookie at the helm. It's just going to have, all you then have is just a sophisticated platform, not the experience behind it. So I think that's a message. That's something that needs to be considered when people do this.
Absolutely. And I'll tell you, I have a good friend of mine, and maybe that's not politically correct, he says, e-ICU is not for a brand new graduate. No. You have to have, you're making decisions on your own, something from your house, based on data that you and your experience, okay? Or even if you're in a center, there's a few attendings, you might be the most senior attending there. So you might be making decisions on your own, you know what I'm saying? And you need to look at the data objectively and see make a good judgment call. So it does take a lot of experience to do that. I'm not gonna lie to you.
Absolutely.
It's a tool, Joe, it's a tool. It's an additional tool.
It's a tool. It's a tool.
With limitations.
Everything has limitations, but you have to have the right person. You have to have an experienced operator, no matter what the tool is. Doesn't make any difference.
Exactly.
You know,
The tool is not going to resolve things for you. And that's why I don't care how sophisticated the system is. I like actually the reactive model, the consult model. I go talk to the nurse doctor at APP, and I contact the consultant, and make your own assessment. Yes, I like the data coming in. That's great. But making my own assessment, I enjoy it. Okay.
well, I'm sure everybody here in the panel, and I'm sure all of you out there probably know that I ask some of the best, most insightful questions. Just ask me, I'll tell you. And I appreciate everything. This has been an incredibly rewarding program for me. I just can't thank everybody enough.